Welcome to AUA Leadership in Business, an official podcast of the American Urological Association.
Welcome to the AUA Leadership in Business podcast, where urologic professionals experience the practical application of business acumen essential to successfully navigating today's rapidly changing business environment. I am Dr. Micheal Darson, and in today's episode, we will discuss contract negotiation for urologists considering a career in private practice. Joining me today for this discussion is Dr. Shinghal, the Medical Director and Chair for Urology at Palo Alto Medical Foundation in Palo Alto and Fremont, California, a multi-specialty medical group in Northern California and part of Sutter Health. Palo Alto Foundation Medical Group employs over 1,600 physicians and APCs. So welcome to today's podcast. Thank you very much for joining us.
Thank you so much for having me. It's a pleasure to be here. And I want to thank the AUA for the leadership and business track and providing all this really useful information to young physicians as well as seasoned physicians. We won't call ourselves old yet.
Exactly. Well, let's go ahead and get started because I think that this is a topic that is going to be of interest to a lot of people. So let's dive right in. Let's talk about practice models. Private practice means different things to different people. Can you discuss different practice models?
Yeah, that's a great question. And I think it's a good way to start our discussion. You know, when you say private practice to a resident just coming out of residency, it's a kind of a black box. You really don't know what it means. And there are a lot of different models where you can be in, quote, private practice. The most simple model is a model where you're a solo practitioner. You own all of the risk. You get all of the benefits. You are the HR manager for your office. You manage all the staff. You manage your rent, your business, etc. Now you may hire people to help you with that, but you are simply managing everything. That's a model that's really difficult to do, but some people still do it successfully. The next model would be something called a large urology group practice, where you have anywhere from 2 to 100 urologists that are a single specialty group that work together and basically use the combined resources of the practice to provide care for urology. They may have multiple offices that is, again, focused on urology. When you start to get into those practices, you can get into ancillary services as well, laboratory services, imaging services, pharmacy dispensing is something that's been coming up, as well as radiation centers, which were quite popular in the 2000s, and those provide sources of ancillary revenue. A more popular model, and the model I work in, is a model called a multi-specialty group, where you have a group of both primary care doctors as well as multiple different types of specialists that are practicing together. The primary care is kind of the base, and then they refer to the urologists that are part of that group. And then finally, there are multi-specialty groups I should say that multi-specialty group model is often based on productivity, where it is sort of make what you earn. The more productive you are, the more that you will potentially make in terms of your compensation. And then finally, there are multi-specialty groups where you're salaried. Examples of that would be the Kaiser Permanente groups or the Geisinger group, where you're basically given a certain salary for the work that you do. It's not based on productivity, but rather just based on the job that's assigned to you. So you have an OR schedule and a clinic schedule, and even if you're busier than your partner, you're going to mostly get paid the same salary. Understanding these different models and what fits for each individual is very important. I think it's important to look inward and say, how much autonomy do I want to have versus how much risk do I want to inherit? Obviously, a solo practice, incredibly autonomous, but a lot more risk. The flip side of that would be a multi-specialty group that, like Kaiser, which has thousands of physicians. There's incredible infrastructure around that, and there will be patients to see. You will show up day one, and your clinic will be full. I promise you when they hire you. And you don't have to worry about billing or collections or anything like that. You just come and take care of patients. And there's every variation in between there. So looking at yourself and deciding what you think would be a good fit for you is important.
So can you give our listeners just some rough ideas of what percentage of urologists that are practicing now are in a true private practice setting or a smaller setting versus LUGPA versus multi-specialty groups?
It's a really important question, and we're seeing a trend here. individual practitioners or small lugpug groups used to be, the dominant group, and we're seeing people really moving towards the employed model with either multi-specialty groups or larger urology groups. The AUA census is a good track of this, and I encourage everyone to try to fill out their AUA census because it does provide some important information. In 2015, about 50% of urologists worked in an employed model. By 2020, that number was nearly 65%, and I only suspect that that number is going to go up. Furthermore, we're seeing more consolidation within medicine. We're seeing large groups such as United Healthcare, Optum, purchasing urology practices. There are urology positions open to work for Optum, the same people that are the pharmacy business manager or the pharmacy benefit managers. So we are seeing this consolidation in medicine where you're working for larger and larger groups. With that, you lose some autonomy. With that, you gain some security and don't have to worry about the billing and collections.
So I think you've done a nice job of summarizing, some of the pluses and minuses of each of these. As a person, I always think of this in terms of, there's somebody coming fresh out of residency, they have very little business experience. And then you have the more seasoned veteran who has, maybe perhaps been in one or two different models. I think one of the things that people need to understand is if you're going to go into a large multi-specialty group and be salaried, the question is, well, if I'm producing a lot, where does that extra money go? And how does it go to support me? And how do I understand that better?
Yeah. If you are working in a strictly salaried model, I mean, the schedules for most of your colleagues are going to be pretty similar. It's pretty standard in terms of how many days of video visits or in person visits you're going to have. And they try to distribute that workload and keep it fairly balanced because you're getting compensated the same. Let's say you're incredibly efficient and you can do 8 cases in an OR day and your colleague can only do 4. Your salary's kind of the same based on that. Now, you may enjoy being efficient and taking care of those extra patients, but there's not a lot of wiggle room in terms of a bonus or anything in many of these salaried structures. Now, if you take an extra call weekend, you might get a compensation time or paid time off in these salaried models. So you get some extra time. But for the most part, if you're super efficient, it's going to get diluted in the big pool and people will shake your hand and thank you very much for taking care of those extra patients. That's not wrong. You just have to be comfortable with it. If you're a person who really likes to get rewarded for their productivity and would resent that, you should be aware of that. Look inward, think about what you're like right now, and if that model would bother you, and for some people they know that right away, then maybe a model that is more based on productivity would be something that would be a better fit for each individual. I encourage residents, and in particular, if you practice in these different models, then you already have an idea. You probably don't know what a solo practice is like, but if you rotate through a salaried model, if you rotate through a Kaiser or something like that, you're going to have an idea of what that looks like and you can talk to the physicians there. I'd encourage everyone to listen to Dr. Berger, who did part 1 of this podcast series. He did a great job of talking about contracts and things, but he also talked about really going out and asking questions. And I want to emphasize that if you have resources of people that graduated from your residency, reach out to them. These are your alumni, and they are happy to tell you what their practice model is like, what they thought about. There is nothing wrong with calling each and every one of those people when you're going through the decision making process and using them as a resource. They'll appreciate the call. All of us love mentoring. I still get calls. I'm 20 years out of residency. I'm 10 years out of doing anything in academics. I still get calls from colleagues who are considering job changes and to look at a contract or something like that. We love supporting each other. It's one of the wonderful things about urology.
Well, and I agree with that. Urology is a great community for sure. But I think that one of the things that I want to emphasize that you hit on that I think is incredibly important is everybody needs to be asking themselves some of these important questions. Because if you're, one of those individuals that's really gung ho about working 12, 14, 16 hours a day, really want to work hard, and you want to be rewarded for it, it seems like you should give more consideration to a model that's going to reward you, because ultimately I think anybody that's working a lot harder than somebody else getting the same pay is probably going to have some form of resentment, and that's just a recipe for disaster. But if you're asking those questions internally before you start looking for a position, that's going to save you a lot of time and a lot of heartache. So I think that's important.
Really well said. And I'll extend that even further. If you're extremely entrepreneurial, working in a multi-specialty group, you may feel somewhat constrained. You may want to be in a LUGPA or a small group that you can be super nimble and offer the latest and greatest, or things that are concierge based or cash based treatments and things like that too. So think about who you are, and you'll find the right fit.
Exactly. Great words of advice there. All right, let's go ahead and move on to probably one of the most important things. Let's talk about compensation. Of course, the immediate question when negotiating a contract is that it's compensation. What elements of compensation should be discussed?
Yeah, great. Thank you for that segue. So, you know, everything is potentially negotiable in a contract negotiation. And Dr. Berger does a nice job again in part one of this. But I will say, as you move to a more of a larger environment, the number of elements that become negotiable start to get smaller and smaller and smaller. So, obviously, if you're joining a three-person group, you can talk about a lot of different things. However, when you're joining a 1,600 or 2,000 person group, the first 10 pages of that contract are pretty much going to be boilerplate, and they will tell you, you are welcome to have an attorney look at this. We're not changing a word of it. And that was told to me when I joined. Now, there are addenda to that contract that certainly could be negotiated, and that typically is looking at your starting salary, and then ultimately what the structure of your salary is going to be like. In if you're joining a pure private practice group like a LUGPA, you're probably going to have initial elements of a starting salary. You're going to have perhaps a ramp up in terms of how they reward you in productivity. And so the private practice models like a LUGPA often are looking at revenue models. So they're looking at how much you actually bring in terms of revenue. And that is based on payer class. Obviously, commercial insurance pays more than some of the public payers like Medicare or Medicaid. And so if you're bringing in less revenue, what you'll want to do is look and see how that compensation is structured. When you move to the multi-specialty groups, the model switches to what we call an RVU model. An RVU, or relative value unit, which many of you have probably heard of, is a measure of work. Some may not, some will say it's not a very fair measure, but everything we do, it has an RVU value, from a follow-up visit at a certain level of service, to a cystoscopy, to a stone case, to a radical prostatectomy. All of these have different RVU values. And your compensation in many of the groups that are based on productivity are based on the number of RVUs multiplied by something called an earnings factor. An earnings factor is simply the dollars times dollars per RVU. So the number of RVUs multiplied by an earnings factor, which is the dollars per RVU. So if you do 1,000 RVUs and you get paid $50 per RVU, you made $50,000. Simple math, right? And that's an increasingly common model that you're seeing in productivity-based multi-specialty groups, that are part of hospital systems or part of multi-specialty groups like I am, where it's productivity-based. Now, again, everything in that model is negotiable. I'll give you an example for our group, and this is nothing proprietary. There is a starting salary that initially is offered, and that is negotiable. The starting salary for our group is fixed for the first 2 years before you become a partner, and then after you become a partner, then you're based strictly on your productivity. In other groups, you may walk in and be productivity based right away, where they may guarantee a certain base salary, and then after that base salary, there is productivity on top of that. So they may say that we're going to guarantee you a salary of 3,000 RVUs worth of work. And then after that, anything above that is paid at a certain amount per RVU. And all of the variations in between are there. Some of those are negotiable, and you could definitely negotiate with the system you're joining, and talk about that earnings factor. But knowing kind of what earnings factors are in your area are very important. It's hard to find. I'll be honest with you. You can find some data about it on national surveys that you can search online, and find out what the generals are. But there are some regional variations in terms of RVUs. So that was a very complex answer to your question. But the things that you're going to want to look at your compensation initially is your starting salary. And then you're going to want to look once after you're made partner, or what the compensation looks like long term, what the ramp up is like, and what your compensation is going to look like 3 years, 5 years, 10 years down the line. And asking those questions is important.
So based on what you've said, would it be fair to say that you probably have more negotiating um, power if you're joining a smaller group versus a larger, more well-established group, given that you said like the first 10 pages of a contract for a big group may be boilerplate and won't be changed? Is that a fair statement, you think?
I would say that you have more items that you can negotiate, and if we want to equate that to power, yes, you certainly could do that. But in terms of compensation, sure, when you're joining a group that is a little bit more flexible and things, you could definitely have more items to negotiate. Again, we are a 1,600 person group. There's very few items. Here you can negotiate your starting salary, but everything else is pretty much when you become a partner in our group. We all get paid the same amount per RVU. It's the same earnings factor per physician per RVU. There is no difference between anyone. We all have the same vacation structure. We all have the same benefit structure, and you're not going to change any of that in larger groups. So I think your comment is absolutely right.
Okay. Let's start talking a little bit about the starting salary and the buy-in. You know, I'm 58 years old. I've seen many different models of initial salary, first 2 years, and then buy-ins. Can you give us an idea of how buy-ins have changed over time?
Yeah. Buy-ins have definitely morphed over time, and again, depends on the environment you're joining. If you're joining a large multi-specialty group, your buy-in is probably going to be something as a more of a token than anything else to make you a shareholder. There's nothing too special there. When you're joining other groups, like a LUGPA, for instance, they may already have equity in some substantial resources, surgery centers, radiation centers, pharmacy dispensing, capital equipment that might be in the practice. And they may ask you to put forth money to reap the rewards of those ancillary services. In large urology group practices, those ancillaries can ultimately account for a significant part of your compensation. Not all of it by any means, but they're definitely it can be a significant part. Some of that's changing now with some of the changes in reimbursement, but it still is significant nonetheless. So you're going to want to understand what that buy-in is going to be. You're also going to want to find out, is that buy-in going to just be taken out of your earnings during your first 2 or 3 years while you're working towards becoming a partner in the group? Or is it some cash that you're going to have to save and then come up with and pay when you decide when they offer you partnership in the group? In general, I would say the buy-ins are changing. We're not seeing as much of that because of the trend you pointed out earlier, where people are moving to more of these employed practices, but it definitely still exists. There are even buy-ins where you're going to go buy someone's practice and you'll be buying their office resources and everything else, and you're going to have to put up some cash beforehand. You're going to want to be savvy about that because it is money coming out of your pocket, and just go eyes wide open to make sure that when you put those resources forward, you're going to be able to recoup the investment that you've made.
Yeah, and I think your point is critical, and I just want to make sure that our listeners understand this, that if you're joining a group where you're going to be buying into equity, I mean, just take a radiation facility, for instance. I mean, those numbers can really add up. So, and I guess my point is to avoid a severe case of sticker shock when all of a sudden you're up for partner, it's very important for you to understand what those numbers are before you start down the track, because the last thing you want to do is get 2 years into a practice, be established, be working hard like your partners, and then all of a sudden you get a number that you just can't handle. And when you could know it up front, I think that's really important. I've seen a lot of potential partnerships dissolve because of that very issue. So I think your point is really a very important one for the listeners to understand.
No, very well said. And look at the changing economics of things too. Radiation as an example. If we move to bundled payments for radiation, how does that change what a radiation center may be making? You may have to pay $300,000 as a buy-in, just as a hypothetical number. Are you going to be able to recoup that over time in terms of what the ancillaries? The other thing is private equity. Private equities are coming, firms are coming and buying urology practices. What does that mean for you? What is your share going to be? What are the changes that private equity is making? Private equity can be a great benefit to certain practices and can provide a lifeline or provide some great resources to allow capital improvement. private equity people are also really good business people, and so they're probably better business people than some of us physicians. So you just want to understand the implications of it when you're joining a practice that is either contemplating a private equity buyout or that has already been part of that. I can tell you in the San Francisco Bay Area, anesthesia groups that have gone through private equity, it has been a soap opera plus in terms of multiple different groups. Some people have done really well with it. Other people have not been as happy with it.
Yeah, for sure. That's a great point. Let's move our discussion to benefits. These can be equally important in a contract. What should urologists be looking for in their benefit package?
Yeah, great. I do think benefits are important, and I think for our younger physicians, this can be as important as a dollar number. We're seeing changing priorities with different demographics. In pure private practices, well, obviously, if you're in solo practice, you're just managing it all. If you're in a LUGPA, they may give you an allowance or something like that, or allow you to just pay for it yourself and then somehow have a potential tax benefit, and you'd have to look into those aspects. If you're joining a multi-specialty group, the basics or the minimum include coverage for your license, your DEA license, fluoroscopy permits, or something like that, or at least a stipend for it. They should be covering those things in general. Health insurance for you and your family. Health insurance is really expensive. Most of us have just, when we're in residency, we don't even know. And if you go and try to buy health insurance for you and your family, it is a shockingly high number for a reasonably for just a reasonable plan. So find out what type of health insurance is offered. What are your options? Is it going to be a high deductible plan? Is it an HMO plan? Do you have more than one option? Where can you go for your care? That's really important to understand. We take our health for granted, but when you start having children, your family grows, you want to have excellent resources and excellent access to healthcare. Um, Disability insurance, very important. We think of ourselves as super people, and yet all of us potentially can have risks of something that could be catastrophic. Ergonomic injuries, neck injuries, hand injuries, and things like that can happen, particularly for surgeons. And so you want to make sure you have a disability policy that accounts for those things, that is specialty specific. This goes without saying. Specialty specific really should be a minimum in your disability policy. What you don't want is some disability company to say, well, you know what? Yeah, you can't operate, but you can still type. I think you can just do family practice. And but that's not what you did as a urologist. You want to make sure that it's really specific to your field. Furthermore, look at clauses for psychiatric issues, drug and alcohol clauses. Most disability policies limit that to 24 to 36 months. I would encourage all residents graduating to look at their group disability policy that they have, because often those disability policies, while you're still in residency, they're a lot more generous, is the bottom line, and you potentially could buy disability insurance before you leave. Initially, I did that 20 years ago because the policy covered a lot of things that that most private practice policies don't cover. So take a look at that before you graduate. Explore that your last year of residency. Other types of things include short-term disability. Long-term disability, which I was just referring to, doesn't kick in for like 6 months or more, and it's a big process. Short-term disability is when you blow out your ACL skiing or playing tennis or something, and you can't function. You want to make sure that you have some coverage there. So that those are some basics that you want to explore, but the benefits are important. Another important benefit is savings methods. That is ways to defer. Um, Urologists, we're blessed. We are compensated very generously. With that comes a tax burden, and you get W-2 income in many of the cases, which is taxed at a very, very high rate in most areas. You're going to be in one of the higher tax brackets. So you want to look at ways to do tax deferred savings, 401k plans, Roth IRAs, pension plans, cash balance plans. All of these different vehicles are going to be important, and you want to understand what they are. In I'll give you an example. Again, for most multi-specialty contracts, that's not going to be in your contract. So what I would ask anyone looking at a job to do is to not only look at the contract, but to ask for some of the policies around benefits. So can you show me what your health plan benefits are, and can you show me the policy? Can you link me to the website? Can you show me the policies regarding each of your savings vehicles and what they look like, and have some? Can I meet with your benefits person and have a half hour discussion so they can go through the benefits as if I was going to be hired? I would use exactly that language if you're seriously considering a job. Before you sign the contract, say, I'd like to meet with the benefits person and just explain it to me as if I already signed the contract so you can understand it really well. I mean, I think most groups who are interested in you are willing to do that. There are many other benefits that are available. FSAs, which are for childcare, health savings accounts, which are a phenomenal way to defer and save monies in a tax deferred way, and then you take it out in a tax deferred way. If you have the ability to save money in a health savings account, it is the best savings vehicle you can do. $7,700 for a family per year. Save all that money till your Medicare age because you can then use that money. It'll grow tax free to pay your Medicare premiums later. Roth plans are very important. And then increasingly important are maternity and paternity leave. Find out what those policies are. If you're a resident coming out, or if you've just been in practice a few years, find out what those policies are and how people manage it. It's very important. You don't want surprises there. Um, the final thing would be CME conference benefits. Most places will offer a stipend or will allow a way for you to deduct your CME costs. All of us need to get CME. In residency, it's really easy to get CME. If you're not taking an academic job in private practice, you actually have to go out and seek it and go to a meeting or at least do things online. The AUA has a lot of great online resources so make sure you understand what those things are. It's not a huge amount of money, but all of these things add up and contribute to your satisfaction. So asking for those policies regarding CME, regarding about deducting tax deductible deductions like your cell phone or your internet. Different groups have those abilities, and you want to just make sure that your group's sophisticated and they can share that information with you.
Yeah, this segment alone has just so much important information. Let me go back and ask a couple questions coming from different perspectives. So, obviously, if you're joining a larger group, they're going to have a human resources department, which is a great resource to help understand these. If you're joining a one or two man group, what would you recommend? Where would you recommend that people seek the information about just the healthcare plans and their deductibles and how they can understand that better?
Great question. I think you'd start with the two other providers that are going to be hiring you, and then talk to their business manager and find out exactly what it's like. You could say, "Hey, Doctor X, you're considering hiring me. Can you tell me what plan you're with? Do you have your insurance card?" And it'll tell you like what plan it's with, and then find out is that the doctors that you currently see, are those within your network or not. They may give you just a stipend for you to go find your own healthcare in some of these smaller groups because maybe they don't want to pay for healthcare in that way. They'd rather just give a stipend. I think that's a increasingly rare model, but maybe not. And so then you want to just price out what insurance is going to look like for you and your family.
Yeah, absolutely. Great advice. And remembering also that the plans will have representatives to help you with questions too. I mean, I think that's also an important resource. Let's talk a little bit about the savings methods because you hit on so many important points there. I mean, being able to defer taxation is an incredibly important vehicle financially. And certainly in the private practice area, you have maybe a few more options. There's the safe harbor, that kind of stuff. So, can you just touch on a little bit about that?
Yeah, you're right. There are literally 10 or 15, if not more, vehicles that you can use. The simplest one is a 401k. We're all pretty familiar with that. If for residents, if you've been able to fund your 401k or a Roth IRA while you're a resident and you're still eligible for a Roth, please do. If you aren't doing it, please do it now. I recommend anyone who qualifies for a Roth to try to put money in a Roth if you can do it, because it is a phenomenal growth vehicle. Pay the tax now while you're a resident and your income level is relatively low. That Roth money will grow and you can take it out tax free later on. But 401ks are sort of the basic. You're going to be able to, you're going to want to find out, how does that work, and what company is it with, where is the money held. In general, it's important to make sure that that money is held by a third party. You don't want that money held by a business manager in their practice who's managing the pension. We all have stories, and I can tell you in the Bay Area, there are stories of incredibly successful practices that fell apart completely because someone or a partner basically embezzled funds from a quote, a totally immutable chunk of money that was thought to be part of the pension. So you want to look at those things and ask hard questions in a nice way. Dr. Berger pointed that out. There's nothing wrong with asking those questions as long as you just do it politely. And if you're not getting the answers you need, then maybe that does raise a red flag. Yeah, you don't want your hard-earned savings going to something that's a joint asset that you really don't have any control over. You want to make sure that there is some fiduciary responsibility around pension plans in particular. Now, if you join a massive group like Kaiser has a pension that's thousands of physicians, and the pension is very, very well worked out in terms of what you get over time. But you have to be there a certain number of years. So going to the other extreme where you're working with a really big group, you're going to want to understand how many years of service do I need? When do I vest into a pension? I worked in a county facility for 10 years, and I had to understand, okay, I need to work there 7 years before my pension even vests. Otherwise, all the money that went into the pension, I don't get any access to it. Um, if A lot of companies offer financial advisors that can offer advice for this at a relatively nominal fee, and it's worth it just to be able to understand things once you're out of residency and starting to plan your financial future.
Yeah, great points. And I would also add that even, coming out of residency, even when you think you don't have any money or you actually don't have any money, it's still a great time to team up with a financial planner so they can kind of go distill all this information down and make you understand how these different financial vehicles can be of benefit to you, not only now but in the future. So that is great advice. Um, a few quick comments about additional benefits like FSAs and HSAs. While they differ completely, I mean, FSAs basically you have to spend all the funds by the end of the year. HSAs have certainly more options, and that's another one where you want to probably get with a financial planner, because HSAs, you can store that money pre-tax, but some HSAs actually allow you to do self-directed investing with it. And you can invest, especially younger healthy people that don't need their funds, they can put that money away pre-tax, self-directed, or under the advice of a financial planner, and let that grow tax-free until they need to withdraw it. So those are really important and powerful financial tools that most people don't really understand, at least initially.
Yours truly here. My wife was like, we should just do the standard one. I don't want to deal with this HSA thing. And you start looking at just what you said, the power of compound interest in a tax-free growth vehicle is just phenomenal. And the HSA is truly like triple tax-free. It's the best vehicle out there. So you summarized it incredibly well.
Yeah, great. Let's go ahead and move on to a topic that has a wide ability to affect a person. Let's talk about ER call coverage. I mean, emergency room coverage for urologists can have significant impact on their practice and their quality of life. What can be negotiated in a contract regarding ER call?
Right. Yeah, as every resident or every physician knows, getting called at 3 in the morning to the emergency room is maybe it's not the highlight of our day. So the first thing you want to know is how much emergency room call coverage are we doing? Are we covering one hospital, five hospitals? Is it mandated as part of my contract, or is this optional? You really want to make sure that that's transparent and find out how often that changes. There are some contracts that there's no question you're going to be covering the emergency room. In other cases, it's a completely independent contract negotiated by a LUGPA with a hospital group to be able to cover that. You want to ask how the call is split amongst the group. Is it equal? Are there seniority clauses? At a certain age, are people allowing to opt out of call? If you're joining a group where everyone's going to turn 63 and that's the cutoff age, and you're the only one taking call, go in eyes wide open. Make sure that that's taken care of. It's happened. I've had to. I didn't personally have to deal with it, but I've heard of stories like that. Um, and then there are some hospitals that are deciding not to pay for urology coverage. So they're shipping all the urology patients to, say, the hospital you're working at. This is occurring in the Bay Area, and it makes the hospital that you're working at extremely busy now. So now you're essentially taking call for two hospitals rather than one. So understanding that call intensity is important. a thing I mentioned to residents is make a call to the emergency rooms that you're going to be going. So let's say you know your local area, but let's say I'm looking for a job in Montana. I might call the local emergency room like, hey, yeah, how often do you call the urologist? I just ask the ER doc there. Make a call a couple different times. Like, can I talk to one of your ER docs? This is Doctor So and So. Ask them. Do you get a lot of urology emergencies? Are those people coming in all the time, or is it not that common? And the ER docs are usually pretty nice about it. They're like, oh yeah, we have a lot of people here with catheters and clotting and stones are everywhere. And other times they're going to like, we never call our urologist. We can take care of it most of the time. The ER docs are pretty nice about that. The final thing you want to look at is stipends for call. Are you getting a paid a separate stipend, or is the ER coverage built into your into your salary? In some cases, like in a large multi-specialty group salaried model, they may give you comp time or paid time off. So if you come into the emergency room for 7 hours over a weekend of call, they will give you 7 hours of vacation. You can't cash it out, but you can take extra time off. In other cases, and this is probably the most common thing for private practice or multi-specialty group, there's usually a stipend that's paid. And this is not proprietary information. This is publicly published information. The average salary across the United States is about, the average stipend, I should say, across the United States is around $750 to $850 per 24 hours of call. And then you'll want to find out, are you allowed to bill for the services that you provide in addition to that? Um, you're going to want to find out how many people are taking call. Is it just your group or is it another group? And how well do you all work together? Sometimes it can be a marriage made in heaven because now you maybe have 4 call weekends the entire year. That's pretty awesome compared to what you're doing in residency. In other cases, you find out that you're going to be taking call once a month for the ER, and that may not be as fun too. So again, asking questions in those different areas is going to be important.
Yeah, I think your advice and your words, eyes wide open, is truly critical in this on this topic because I think, and please weigh in on this. ER call coverage is a huge quality of life issue, and I would tell, especially residents coming out. Again, I think more seasoned doctors switching practices are gonna definitely talk about this. But I would say don't be afraid to ask your future partners just how bad the call is. Have that really honest discussion because the last thing you want to do is, say target an area that you really want to live in, but then realize that the ER call is just a huge negative quality of life issue that really negatively impacts your life. So I think those are really important questions to ask.
Yeah, completely agree. And I think fairness in terms of how call is distributed also affects that as well too. If all 8 of your partners are equally suffering, maybe it feels a little bit less. But if 3 people aren't taking call anymore and they're sticking it with other people, you bristle at that a little bit more. But I completely agree with everything you said.
Yeah, definitely. All right, let's talk about some nuts and bolts of everyday practice. Let's talk about practice environment and clinic staffing. Obviously, compensation is important, but the clinic and operating room environment in which a urologist practices is critical to satisfaction and success. What should urologists ask about when considering a new position or contract?
Um, so I think this is as important as anything we talked about because they may pay you a boatload of money, but if you're not happy where you're practicing, it just doesn't matter. When all is said and done, it's not what your bank account says. It's like, am I happy or am I not happy? And so understanding what the clinic environment is like is very important. I First thing, if you're looking at a job, I think it's important to go spend at least some time shadowing that practice. See what the office interacts like. Is it chaos? Is it smooth? What do the staff feel like? Are they happy? Are they not happy? You're going to get a sense for that in 20 minutes when you spend there. If a practice isn't going to allow you to do that, that's actually a red flag to me. I think most practices are like more than happy to invite you in and see what my clinic schedule is like and talk to my staff, talk to my nurses, talk to my medical assistants, see what it's like. Go out to the waiting room. Is the waiting room total chaos with people standing there and yelling at the front desk? Or is it a controlled environment, something that you would be proud of to work with? Look at those things and ask those questions. In the contract itself, there'll be some contracts where you really you can try to negotiate what access you're going to have to exam rooms. Now, they may not be specific in terms of what they'd have, but you might be able to have language in there that would say that you're going to have equivalent access or equivalent number of exam rooms and equipment as the existing partners. What you don't want to do is come into a practice that puts you on a productivity compensation. So you have to make 8,000 RVUs and they give you one exam room, and you're just not going to be able to accommodate that. Or you go to a practice that has 2 cystoscopes, and oh yeah, well, the senior partners kind of use those most of the time, so you're going to have to cysto your patients another time rather than offering the care you want to deliver. Looking at those things are important. In the contract itself, you're probably not going to be able to write in capital equipment, but understanding what kind of capital equipment they do have is important. As I mentioned, cystoscopes are important, ultrasound machines, um, bladder scanners, urodynamics, if that's something you're interested in. Knowing what's in the practice right now and what you need is important. This is one of my old faculty members said, the best time to ask for stuff is when you get hired, because it's the honeymoon period. So if there are things that you're going to need to be a successful urologist in your practice, ask for them now or come up with a plan to get them. If there's a specific thing, let's say you're an infertility specialist and you need a particular ultrasound to be able to do penile Doppler as an example, make sure you have that. If you're a female pelvic medicine and reconstructive specialist, do you need a urodynamics machine? And what's the capital equipment plan to be able to get that for you to be able to practice how you want? Make sure that you have some language in there, or at least an understanding with the practice about that. When you switch to the operating room, understand what block time is going to look like. If you're operating in a hospital, do you have access to a robot? Do you have access to block time that's shared amongst the group, or is there a hierarchy? How is that going to be worked out? What are the wait times? So I see a new patient with prostate cancer, and I'd like to do his prostatectomy. When can I get into the operating room schedule? Am I doing these cases at 8 o'clock at night because I'm the junior partner? Or am I going to be able to get access to time like everybody else and it's equal? Make sure you ask those questions. It's okay to ask them in a nice way. I don't think anyone bristles at that. And if they're honest with you, you're like, yeah, you know what? You're just going to be doing add-ons at 8 p.m. You should at least you're aware of it. And now you know you're going to be doing your prostatectomies at 8 p.m. at night. So understanding that is important. Where you operate. Are you going to be operating at 7 different hospitals to be able to get your cases done? Or is it going to be at surgery centers? What does the surgery center allow you to do? And what's the privileging requirements there is very important. The final thing is to look at future growth plans. So understanding who's leaving the practice and how's it growing. What's going to be happening with this practice in the future is important. And it's great to ask them, like, where do you see this practice in 1, 3, 5, and 10 years? And what are our goals? You want to be in a practice that's growing, not contracting. That's going to fit your goals as a successful urologist. But the most important question is, are the folks that you're going to be working with happy? What's the turnover been like in that practice? Are they going through new urologists every 2 years? That's a big red flag, right? You don't want to be joining something like that unless it's for good reason. I mean, maybe people had family issues or something, but you want to know why that is. But ultimately, the advice I tell people, and in the talk we gave at the AUA, it's pick the job for people, not for payment. If you pick a job with great people who are going to treat you respectfully and they support you, and you go to, at the end of the day, you feel like you're being treated fairly, that dollar amount on your paycheck isn't going to matter as much because you're going to be happy. The converse is not is also true, that you may have a phenomenal compensation plan, but if you feel like you're being treated disrespectfully, and you're not enjoying your partners, or you don't feel they're practicing the medicine you would practice, you're not going to be satisfied, and it doesn't matter how much money you have. So I'll stop there.
Now, I cannot echo strongly enough what you said at the very beginning of this segment. Is this is just as important as everything we've talked about today. And even if you're coming from an established practice or you're fresh out of residency, don't assume that you're walking into a practice that functions as efficiently as where you've trained or where you've had an established practice, because you can change practices and it can be completely different. So I think, when you say, shadow a partner, I think some people would, especially new residents, are like, oh man, last thing I want to do is shadow somebody. But like, if you're with somebody in the OR, and what you can do is look at the efficiencies of how the rooms are turned over. I mean, are you looking at 20-minute turnover, or are you looking at an hour and a half of turnover? And obviously that's going to impact how efficient you can be. And listen, I mean, it, nobody's happy with 90-minute turnovers, right? And if that's the standard of the hospital that you're looking at, you need to understand that, because unless you can go in and change it, which is going to be a long process, you're looking at some frustration there. So I think that's really important. And you can even talk to the OR manager and maybe even get some statistics on that for cysto rooms versus robot rooms and that kind of thing. And it's really important. And those are your point about, those are really good questions. I mean, don't be afraid to ask those questions. So that was a really good point. Understanding the OR time, again, very critical, because I mean, sometimes and when you're a junior partner, you are starting your cases at 5 o'clock. What's the pathway to get block time? How many cases do you have to do, or what do you have to do? So again, really important. And I know that you touched on this a little earlier, but I just kind of want to, this seemed like a really good segment to talk about it again. Future growth plans. I mean, private equity and VC companies are all over the landscape now. How would you counsel somebody that if their practice is getting looked at or has been in contact with a private equity group, what are the questions that you want to ask in that regard?
Yeah. My first disclosure is I'm not a private equity expert, but I would say that there are a number of things you're going to want to look at there, including the time frame. When are they looking at this acquisition? Is this something that's going to happen after you have full equity in the group, or is it going to happen while you're an employed physician as part of that urology group? That's important because you will get no benefit from the buyout by a private equity firm on the premium because you have no equity in that group. What's Has private equity or have the particular private equity firm purchased any other urology practices? They'll be Now they may not be able to disclose that if it's a confidential negotiation, so you may not know who they're looking at. But if you can find that information and find out is that firm worked in any other venue and have they bought any of the practices, call those firms. Urologists are friendly people. They'll be happy to talk to you about it and tell you what it's like. Um, there are certainly situations where the staffing changes with private equity. I mean, private equity firms are investing in things to get cash flow. That's what private equity does. They want to get cash flow, and they're really, really smart business people. Urologists do generate a lot of cash flow, but is that generation of cash flow coming on your back? Is it going to be that your overhead suddenly goes from $300,000 a year to $600,000 a year or something like that as an example? And has that been the trend? Ask those questions for the partners that have already had a buy-in with private equity and what the overhead numbers are going to be like in certain groups. Again, private equity can be really beneficial in certain practices to allow them to grow, to build surgery centers, to find ancillary revenue streams, to expand into other areas and hire. Private equity also can have some negative consequences depending on how it's done. So just make sure that you understand the implications of that. There are even consultants out there that do private equity sort of acquisitions and can counsel people about that. Usually, urology groups will employ some of these people or bring them in as consultants to help with that. Um, if you're a brand new junior partner coming in, I'm not sure that joining a group that's just going to get bought out by private equity is necessarily going to be a good thing for you. You're going to be working for a private equity firm and you don't get any of the benefit for that. But if they're ultimately going to make the practice flourish, that still could be a benefit as well too. Again, knowing what you potentially can expect is a lot better than not knowing anything at all. And so just knowing the potentialities out there is good. At least you're not going to be surprised when they're like, oh, hey, by the way, we sold to the private equity firm and now your overhead is $600,000. It's like, oh my. Yeah. No one wants that news.
Yeah, no, those are very important points. Thank you for making them. The last thing I'd like to just go back and emphasize again that you already talked about is asking your partners. I mean, ask them the important questions. I mean, are they happy? And I would say also go a step further and say, hey, can I contact the last person or two that's left the group? And if it's not for a personal reason, just ask them, why they left, and are those reasons important to you in your decision making?
Really good point. Yeah, that's exactly right. Very, very well said. And you often find out a lot about what the practice is like talking to the nurses and the clinic managers and everything. Your medical assistant, your nurse will, if you see what they're like and if they're smiling and joking around and everything, that's a happy place to work. And you know what? Then it's not work. Then that group becomes your friends, and it's not, there's always an aspect of any practice that's work. But when you're working with people that you enjoy working with, it can be a lot of fun. But I think that's a great suggestion on your part, Mike.
Dr. Shinghal, thank you so much. This has been a really good discussion. Thank you for sharing your time and expertise with us today.
Well, I really appreciate the invitation. Again, thanks to the AUA for this curriculum. I think it's valuable for all of us, and do appreciate participating.
And thank you to our audience for joining us on the AUA Leadership and Business Podcast.
Thank you for listening. If you enjoyed this episode, make AUA Leadership in Business your go-to podcast. Subscribe today by searching AUA Leadership in Business on your favorite podcast app and enhance your leadership and business education needs.